Hey, this is Doug with No Stress Training, and in a continuation of videos helping you get ready for ACLS, we're about to go into the easiest protocol in all of ACLS, believe it or not, and that's the cardiac arrest protocol. The reason I claim that the cardiac arrest protocol is the easiest protocol in ACLS is because it has you repeating the same actions over and over and over in these very regimented, very disciplined 2-minute blocks. And there's nothing you really even have to memorize. If you learn the rhythm of these 2-minute repeated cycles of activity, you'll do that until you either resuscitate the patient or you call for code termination. So let's go ahead and get started. First of all, when a patient goes into cardiac arrest, there have been numerous studies that have determined that there are a sequence of actions that really have no statistical difference in the outcome for that patient, and then a series of actions that significantly impact resuscitations. In this list of categories of things that have very little to do with resuscitation rates includes how many people with advanced degrees are present in the room, how expensive the equipment is on the wall in the room, what drugs are available in your crash cart, and even whether there's a plastic tube inserted into the patient's trachea during the code or not. All of those criteria are statistically insignificant in resuscitation rates. So what does make a difference for resuscitation? There's two things. Number one, the physical quality of the mechanics of the chest compressions that are being done. And number two, the availability of a defibrillator for patients in shockable cardiac arrest. So for that reason, the cardiac arrest protocol has you doing these 2-minute blocks of high quality CPR punctuated by these very short interruptions where the team has 3 responsibilities that they have to take care of. Now let me go back to the CPR again for just a moment. As part of your ACLS certification, they require BLS skills verification. And people ask me, why do I have to do CPR in an advanced curriculum course like ACLS? And again, I drop back to the fact that that is the key criteria that determines whether a patient survives from cardiac arrest or not. Understand that the very best performed CPR only produces about 30% of normal cardiac output, and the pulseless body needs every drop of that, and they won't be getting that if my hand position is wrong, or my depth is too shallow, or my speed is too fast or too slow, or I don't have good recoil, or I'm not coordinating well with the ventilator. So every person on the team during every minute of the cardiac arrest protocol is responsible for quality assurance, which means that if you look over and you see something wrong with my CPR, you give me verbal feedback on that immediately. We don't worry about hurting anybody's feeling. It should be an understood part of your code that constant feedback and constant critique of the CPR is a critical part of the patient's survival. Now, when the patient is first recognized to be in a pulseless state, we don't start with this protocol. Instead, we start with the CPR BLS protocol. Hey, are you okay? Wake up, are you okay? There's no response. Call a code, grab the crash cart, check pulse and breathing. There's no pulse. Begin CPR. Now CPR is not done for a full 2 minutes at that point in time. It's done only until the defibrillator is brought to the patient's bedside, whether that's an AED or a manual defibrillator like we have here. And as soon as it's available, it's used immediately, because ventricular fibrillation is a time-sensitive arrhythmia, and the longer you wait to defibrillate it, the less chance of resuscitation you have. So we defibrillate immediately as soon as the defibrillator is available in coordination with the CPR. That initial shock decision is what starts this protocol. From that point on, every block of CPR is timed out to exactly 2 minutes. If you're using a device like an automatic external defibrillator, that timing is mandated upon you by the programming in that AED. That AED, once every 2 minutes, is going to tell you, don't touch the patient, stop doing CPR, analyzing, shock, and it'll tell you to start doing CPR again. In the absence of a machine like that, you've got a recorder or someone on your code team who's watching the clock who tells you as the team leader, hey, we're 17 seconds from the end of this block of CPR, get ready for the 2-minute break. Now, the reason they tell you that is because at the 2-minute break, you've got things that you've got to do and you've got to be prepared for that. The number one thing that you're going to do at every 2-minute break when the recorder says 2 minutes is now is you're going to change compressors. One person cannot effectively produce good quality chest compressions for 4 minutes. So every 2 minutes, even a fit, healthy person is replaced with a brand new set of muscles so that chest compressions can be continued with the same intensity and ferocity that you have to have going on the entire code time. To arrange this and make it happen very quickly and efficiently, when you know the 2-minute mark is coming up, you're going to pre-designate your next compressor. So if Dina's doing compressions right now and you know the 2-minute mark is coming up, you're going to say, Doug, I want you to take over compressions at the 2-minute mark. And using good closed loop communication, I look back at you and I say, I'm taking over compressions at the 2-minute mark. And I position myself behind the current compressor, and when the recorder says 2 minutes is now, that person steps away, I step forward, I find my hand position, and I begin with no prompting in order to minimize the interruption in CPR. Now, the second thing that has to happen has to do with the cardiac monitor. This is the patient's rhythm in this situation, and it happens to be ventricular fibrillation. But you know what? In a real code, I rarely get to see that. And the reason for that is because of the movement artifact associated with compressing the chest. I've got a button on this rhythm generator that simulates the effects of CPR on a cardiac rhythm. That is not the patient's rhythm. What I'm seeing right there is movement artifact, and that's all I see during most of the code while CPR is ongoing. As a team leader, I don't want to turn to my team and say, stop doing that life-saving CPR so I can get a glimpse at the rhythm. Instead, what happens is once every 2 minutes, the compressors change. And when one compressor steps away and the next compressor steps up and finds his hand position and then begins, I was presented with 3 or 4 seconds of motionless patient EKG in order to do a rhythm analysis. We perform our rhythm checks once every 2 minutes in conjunction with compressor changes in order to minimize interruptions in CPR. And then finally, the reason we do a rhythm check once every 2 minutes in conjunction with the change in compressors is to see if we still have a shockable rhythm. Shockable rhythms include ventricular fibrillation and pulseless VTAC. If you see either of those 2 rhythms, each time you do a rhythm check, you should immediately shock VFib or pulseless VTAC. As soon as that shock is delivered, you set a new 2-minute timer. And we stand around as a team and we troubleshoot CPR for 2 minutes. At the end of 2 minutes, the recorder says, hey, 2-minute timer's coming up. We change compressors. While the compressors are changing, we look at the rhythm. And if the rhythm shows VFib or pulseless VTAC, we shock it. And we repeat that sequence of actions again and again and again for as long as we work the code, every 2 minutes. Now, that is the skeleton of the cardiac arrest protocol. In the workbook that we supply, there is a copy of the ACLS protocol, which is represented by a circle. And that circle simply represents the fact that you do the same thing every 2 minutes. It takes 2 minutes to go from the top of that circle all the way around back up to the top again, and then you repeat. We have the protocol in there as a series of bars showing that you repeat the same blocks of CPR, and every 2 minutes you change compressors, and while the compressors are changing, you check the rhythm, and if you see VFib or pulseless VTAC, you deliver a shock. Now, something that is missing from this protocol, and something that I have intentionally not added until last, is the medications. Medications do not resuscitate patients from cardiac arrest. It's the CPR and the shocks. However, medications are a good supplement to CPR and shocks, and therefore should be used as a supplement to those therapies. The primary medication that is mandated in cardiac arrest, regardless of the patient's EKG rhythm, is epinephrine. Epinephrine can be delivered when you get at vascular access, and often that's not immediate. Often that's the first or possibly even second bar of CPR into the code. But when you have vascular access, there's no reason to withhold a dose of epinephrine. The dose of epinephrine in cardiac arrest is 1 milligram rapid IV push of a 1/10,000 solution. Now, what's the value of epinephrine in a code? If I went into cardiac arrest right here, right now in front of you, the first clue that you would have that I was having a problem would be me hitting the floor. And the reason for that is that obviously a person in cardiac arrest can't maintain skeletal muscle tone. You can see that. What you can't see, though, is at that exact same moment that I lose skeletal muscle tone, I also lose vascular muscle tone. And my peripheral vasculature dilates out to its very largest volume. Well, as a well-meaning healthcare provider, you come down, you've assessed that I'm pulseless, and you start doing CPR, but you're doing CPR on this gigantic vascular vessel, and you're not generating very good perfusion pressures until somebody comes along and pushes that 1 milligram of epinephrine. That epinephrine restores a degree of peripheral vasoconstriction and shunts perfusion pressures back to core organ systems. Although epinephrine is not responsible for resuscitation, it is the most superior drug that we have for improving cerebral, pulmonary, and coronary blood flow during chest compressions. It's a CPR booster. As a matter of fact, the administration of epinephrine has nothing to do with the cardiac monitor. The indication to push epinephrine during a code is the fact that you're doing chest compressions. Epinephrine also metabolizes very quickly, even in a pulseless body. And the traditional dosing schedule has us giving epinephrine in the same dose of 1 milligram every 3 to 5 minutes. But with the adoption of these 2-minute blocks, the American Heart Association encourages you to deliver 1 epinephrine in every other alternating block of CPR, which puts them 4 minutes apart and places them in perfect therapeutic range. Epinephrine metabolizes quickly and cleanly, even in a pulseless body, and there is no maximum dose. As long as you're working the code, you can deliver 1 milligram of epinephrine in every alternating block of CPR. A second drug that is used in the cardiac arrest protocol is tied to the cardiac monitor, and that drug is amiodarone. Amiodarone is a ventricular suppressant, ventricular antiarrhythmic. And it does not metabolize quickly or cleanly. As a matter of fact, once you've given amiodarone in 2 doses, you're done with it. Those doses are delivered, if appropriate, based on rhythm check, between the initial doses of epinephrine. The first dose of amiodarone front loads the drug at 300 milligrams. The second and final dose, if indicated, gives amiodarone again in half that dose, 150 milligrams. Once you've delivered 300 and 150, a total of 450 milligrams of amiodarone, you've maxed that patient out on bolus amiodarone for 24 hours. Amiodarone is not mandated during cardiac arrest, but it is recommended based on potentially helpful effects in studies on amiodarone. Now, you're not going to find this fact on the test or in the literature or even on the protocols because it was delivered to us as a digital update to the protocols last year. And that's the fact that if you choose to, at physician discretion, substitute lidocaine for amiodarone during cardiac arrest. Lidocaine is a dose, is dosed according to patient weight. It's delivered at 1 to 1.5 milligrams per kg for the initial dose, and then subsequent doses at half dose, which would be 0.5 to 0.75 milligrams per kg to a maximum of 3 milligrams per kg. I can't tell you why you'd want to switch to lidocaine instead of amiodarone, except maybe economics. Recognize that amiodarone is tied to the cardiac monitor, as are shocks, and they both require that the patient remain in refractory VFib or pulseless VTAC. So this sequence that you see up here with 2-minute blocks of CPR, every 2 minutes we change compressors, we check the rhythm, we see VFib and we shock, and then we push either an epi or an amiodarone, followed by an epi and another amiodarone and then another epi, is done when the patient remains in a shockable cardiac arrest for a long period of time. But I'll tell you, that doesn't happen. If we didn't do anything for a patient in ventricular fibrillation, it would terminate itself in fairly short order. Ventricular fibrillation and pulseless VTach are self-limiting arrhythmias, and they convert within just a few minutes in most cases, and we're doing things to try to make it convert. So it's very likely during one of these rhythm checks you're going to look over and you're going to see something other than VFib. And unfortunately, most frequently, that thing you're going to see is going to be flatline, asystole. Now, there could be a treatable reason why your patient went into asystole, and you should investigate that using the H's and T mnemonic from the cardiac arrest protocol. But the American Heart Association literature that goes with asystole is pretty blunt. They say that the reason most older adults go into asystole during their code is because they're dead. And the recommendation is that you do a reasonable degree of resuscitation effort and then you terminate that code. Now, the term reasonable is what's up for debate. They don't try to define that. Reasonable is going to be situational according to your judgment, your team's intervention capabilities, and family wishes. But what does happen up here when the patient is asystolic is that the shocks disappear and the amiodarone disappears. So what's left for asystole? CPR and epinephrine and a search for a potential underlying cause. When we terminate a code in an adult patient, the code rhythm is most often asystole. Recognize that a patient in VFib, pulseless VTach, and PEA are potentially viable, but the patient who's become asystolic is showing you there's really nothing there left to work with. All right, that's not the only possible thing you'd see during a rhythm check. It's really possible that when you do your rhythm check, you could turn around and you could see something like this. Now, I paused the rhythm monitor there because I want to really emphasize the fact that during this entire code, you have not stopped and checked pulses because the patient hasn't given you any indication to do so. But upon a rhythm check, the identification of a single QRS complex is considered a sign of life, and that is the first opportunity for you to turn to your team for the first time and say, stop doing CPR because I want you to check a pulse. Now, when you check a pulse on this patient, you're hoping that this return of electrical viability also indicates a return in pulse and you've got a resuscitated patient. But that doesn't have to be the case. A patient can get back a viable rhythm, and it doesn't have to be something gorgeous like sinus rhythm. It could be atrial flutter, it could be sinus bradycardia, it could be an idioventricular escape rhythm. If it's got QRS complexes and it doesn't have an accompanying pulse to go with it, it is PEA, pulseless electrical activity. Now, the occurrence of PEA is sort of bizarre, because the vast majority of adult cardiac arrests occur because of derangement of the electrical conduction system in the heart, VFib or pulseless VTach. Well, that's not the case anymore. So if my patient is not in cardiac arrest because the electrical system is all jacked up, then why are they still pulseless? And the answer to that is going to fall into one of three realms. It's chemical, it's metabolic, or it's hydraulic. To address those three realms, we want to go to the H's and T's, which include things like hypoxia, hypovolemia, hypothermia, hypoglycemia, hydrogen ion, hyperkalemia, which represents all of the electrolyte imbalances, tablets, toxins, trauma, thrombosis, pericardial tamponade, tension pneumothorax. The list is in your cardiac arrest protocol, and it's comprehensive, and it sounds like an awful lot of work to go through to try to rule out all of those things. But in real life, you most of the time know why your patient's in PEA. If I come into your facility clutching my chest and you do a 12 lead on me that shows a STEMI and you know I'm having a heart attack, and then I keel over in a PEA cardiac arrest, you know you're dealing with a coronary thrombosis. If I'm a patient that's been brought in after being ejected 60 miles an hour out the windshield of my pickup truck and I'm in PEA, you know I'm all busted up inside. You're dealing with trauma. But here's the number one reason why we see patients in PEA. This guy was in cardiac arrest, and it was a shockable cardiac arrest. He was in VFib. We've done CPR, we've ventilated, we've pushed epi, we've pushed amiodarone, and most importantly, we've defibrillated at appropriate points. And during one of the checks after defibrillation, we find this rhythm without a pulse. In that case, we have converted a VFib heart to a sinus rhythm heart. And that heart, if we could see it, is probably beating. there are contractions. There is blood being ejected out the aortic valve. But it's such a miserably low blood pressure that my human fingers can't feel those palpable waves of pressure through the carotid arteries. Why? Because the patient is massively vasodilated and they've got terrible inotropic contraction because the heart is so hypoxic. So what do we do about that? How do we restore a pulse in this PEA patient? Number one, you keep doing CPR. Continued CPR will push cold acidic blood out of the coronary arteries and cause that blood supply to be resupplied by blood that is better oxygenated, warmer, and has better energy substrates coming from areas like the extremities. Two, if it's time, you're going to give epinephrine according to its schedule to promote that peripheral vasoconstriction and increase systemic vascular resistance. And three, you're going to hang a big fluid bolus, which is going to help with that peripheral vasodilation, the vasodilation that you have in cardiac arrest. So what you're doing is you're actually treating this patient for profound hypotension while continuing CPR. If you do those steps, continued CPR, continued epinephrine according to its appropriate schedule, and fluid boluses, the next time in 2 minutes when you get to see this rhythm and check a pulse again, it's likely that you'll get that pulse back. I always tell my guys that work for me that when they have a PEA patient like this, if they'll do the right things, what they're dealing with is a patient who is halfway resuscitated and a little bit more work, and they've got them there. All right, that concludes the discussion for cardiac arrest. This is really simple. And the big key is just learning how to manage a team, how to put this together. And when we have a chance to get together and do our practical exercises, we're going to practice this so many times that you guys are going to learn that rhythm and you're going to realize how easy this is. Okay, thanks. And we got one more protocol to cover, and that's going to be post-resuscitative care, and we'll be right back with that.